Welcome to Medsamu Medicine Podcast. I'm your host.
And hello from me.
Today we're diving into a really common issue, something you'll definitely see, well, all the time really, tennis elbow.
Lateral epicondylitis, yeah. Super common.
Exactly, and crucial for exams too. So we're going to break down, what it is, how you spot it, and the latest on managing it.
Sounds good. We've looked at a fair bit of the current thinking on this.
Right. The goal is to give everyone listening, whether you're studying or already practicing, a really solid practical handle on it.
Okay, let's jump in. The absolute hallmark symptom. It's that pain right over the outside part of the elbow.
It's a lateral aspect.
Precisely. And it's typically, well, it can be sharp, often comes and goes.
Mm-hmm.
And the big thing is it gets worse with repeated wrist expansion, like really flares it up.
And patients often feel it traveling down the arm too, don't they?
They do, yeah. Sometimes radiating along the forearm, maybe even down towards the wrist.
Now, we call it tennis elbow, and sometimes it is from a specific thing, like a bad backhand.
Right, the classic trigger.
But often it seems to creep up more slowly, like from repetitive stuff.
Exactly. It's often got this insidious onset, things like using a screwdriver over and over, or even just lots of typing can definitely contribute. It doesn't always have to be a sudden injury.
Okay. And if you had to put your finger right on the most tender spot?
Usually it's about, maybe 1.5 centimeters distal to where that main muscle involved, the extensor, carpi, radialis, brevis.
ECRB.
Right, the ECRB, where it originates. So just slightly down from the bony bit on the outside of the elbow.
Now, here's something interesting. Despite the apiitis and epicondylitis, it's not really just inflammation, is it? Especially long-term.
That's a key point.
Yeah.
We used to think of it purely as inflammation, but the understanding now is more about microtrauma leading to tendinosis, specifically angiofibroblastic tendinosis.
So degenerative changes.
Yeah, basically, it's like wear and tear at the tendon origin with abnormal little blood vessels and fibroblast cells. It's not a classic inflammatory picture after the very initial phase.
Which explains why just relying on anti-inflammatories might not fix the underlying issue.
Exactly. It points towards treatments that aim more at tissue healing and remodeling. And this underlying tendinosis, it leads to that other common complaint, weaker grip.
Ah, yes. Patients often report that, don't they? Painful gripping.
Definitely. Even simple things like, turning a door handle, lifting a kettle, or carrying shopping bags can really bring on the pain. Because gripping tenses that ECRB tendon. Prolonged or forceful gripping is often a major aggravator.
Okay, so let's talk examination. When a patient comes in with this lateral elbow pain, what are the absolute must checks?
Well, number one is palpation. You're looking for that specific tenderness right over the lateral epicondyle.
And like you said, maybe just slightly distal to it.
Usually about 1 to 2 centimeters distal to the ECRB origin. That's often the point of maximum tenderness.
But it's not just about pressing on it. We need to provoke it functionally, right?
Absolutely. Seeing if you can reproduce their pain with resisted wrist extension is probably one of the most indicative signs.
Because that directly stresses the ECRB.
Exactly. And if you combine that wrist extension with having their hand tilted outwards towards the thumb side, that's radial deviation, and their palm facing down, pronation.
That puts even more strain on it.
It does. It really increases the force going through that specific tendon origin. So pain with resisted wrist extension, especially in that position, is a strong clue.
And then we have those specific named tests, the provocative maneuvers.
Right, the classics. The coffee cup test is a simple one. Does lifting a full, heavy mug cause that lateral elbow pain? Surprisingly often it does.
I can imagine that being quite specific.
It seems to be. Then there's Mills' test. For this one, the examiner passively takes the patient's arm, pronates the forearm, so palm down, then fully flexes the wrist, so bending it down, and then extends the elbow straight, all while palpating that lateral epicondyle.
And a positive test is?
Reproduction of their familiar pain right over that spot.
Got it. And Maudsley's test, what's that targeting?
Maudsley's is looking more at the extensor digitorum muscle, which is nearby. You ask the patient to keep their elbow straight, forearm pronated, and then resist them as they try to straighten their middle finger.
Just the middle finger?
Just the middle finger against resistance. If that causes pain at the lateral epicondyle, it suggests involvement of that muscle's origin too.
Interesting. So multiple ways to stress those extensors.
Yeah, they help confirm the diagnosis.
Yeah.
One thing to note, though, you don't usually see much swelling or redness with tennis elbow.
Yeah.
Maybe a tiny bit in the very early acute phase, but typically it's not an obvious visual finding.
Good point. Okay, so we've got a likely diagnosis, but elbow pain can come from other places. What's on the differential list?
Definitely need to think about the neck, cervical radiculopathy, especially C6 or C7 nerve roots.
How would that present differently?
Well, you'd be looking for pain radiating from the neck, maybe numbness or tingling down the arm, potentially specific muscle weakness or reflex changes related to that nerve root. It's often a different pattern than just localized elbow pain.
Right, check the neck exam. What else? Closer to the elbow.
Posterior interosseous nerve entrapment,
Ugh.
sometimes called radial tunnel syndrome, although they're slightly different. PN syndrome causes motor weakness.
Okay, tell me about that one.
So the pain might be a bit more distal, say 3 to 4 centimeters down from the epicondyle, more over the dorsal forearm. And crucially, you might see weakness in finger and thumb extension and maybe some wrist extension weakness, but typically no sensory loss.
Yeah.
The tenderness is also usually lower down.
Different location, nerve symptoms. Got
Sure.
it. What about joint issues?
Osteoarthritis of the elbow,
Mm-hmm.
more common in older folks or those with previous injury. You expect pain, maybe stiffness, reduced range of motion, and potentially that crepitus, the grinding feeling on movement.
Makes sense. Anything else? Maybe less common?
Yeah, a few others to keep in the back of your mind. Osteochondritis dissecans, that's a cartilage and bone issue, often in younger, active people. Causes activity pain, swelling, maybe mechanical symptoms like locking or catching. Osteonecrosis, bone death, basically.
Mm-hmm.
Less common maybe in kids or related to steroid use. Insidious pain, worse with activity, maybe limited extension. And then pica synovialis, synovial fold syndrome.
Plica.
Yeah, a fold of the joint lining getting pinched can happen in athletes, causing pain, sometimes clicking or snapping.
Okay, quite a list. So, given all that, when do we actually need imaging? Is it always necessary?
That's a great question, and the answer is usually no. The diagnosis of tennis elbow is overwhelmingly clinical. It's based on the patient's story and what you find on exam.
So history and physical are key.
Absolutely. Lab tests aren't helpful, and imaging usually isn't needed for the initial diagnosis.
But sometimes.
Sometimes, yes. If the symptoms have been going on for a long time, or if they're not responding to standard treatment, or if there's something atypical about the presentation, then imaging might be useful.
Like an X-ray.
An X-ray can help rule out other things, like that osteoarthritis we mentioned, or maybe loose bodies, Osteochondritis dissecans, or bone spurs. Interestingly, in some chronic resistant cases, X-rays might show calcification in the soft tissues near the ECRB origin.
Okay. And MRI, when would that come into play?
MRI is generally reserved for situations where you have a strong suspicion of something else going on that the X-ray didn't show, like a more subtle cartilage issue, a stress fracture, or maybe to get a better look at the tendon itself if you're considering surgery or if the diagnosis is really unclear, but it's not routine.
Right. Diagnosis is mainly clinical.
Yeah.
So let's move to management. We've diagnosed tennis elbow. What are the first steps?
First off, identify and stop, or at least significantly modify, the activities that are clearly aggravating the pain. That's crucial.
Makes sense. Avoid poking the bear.
Exactly. And in the early stages, sometimes just watchful waiting combined with that activity modification is enough. But, and this is important, you don't want complete inactivity or immobilization.
Why not? Seems intuitive to rest it completely.
Because prolonged rest leads to disuse atrophy. The muscles get weak. And weaker muscles can actually make recovery harder and take longer. So it's about modifying, not totally stopping, movement. Finding ways to do things differently, maybe with less force or repetition.
Good distinction. What about simple symptom relief?
Ice is often helpful, especially early on or after activity. Just applying an ice pack for, say, 15-20 minutes can reduce pain and maybe some local inflammation through vasoconstriction.
And those straps people wear, counterforce braces.
Yes, those can be quite effective for some people. It's a strap worn around the forearm, usually about 10 centimeters, maybe 4 inches, below the elbow joint.
How do they work?
The idea is that they change the pull of the muscles. They create a sort of new artificial origin point for the muscle force, reducing the tension right at the inflamed epicondyle attachment. Studies show they can improve rest pain and even increase grip strength after a few weeks.
Okay, so activity mod, ice, maybe bracing. What about medications?
NSAIDs, non-steroidal anti-inflammatory drugs, are often the first go-to for pain relief. Both topical gels or creams applied directly to the area and oral pills.
Do they fix the underlying problem given it's more tendinosis?
They mainly help with pain, especially early on. But looking longer term, some evidence suggests that using oral NSAIDs combined with physiotherapy actually provides better pain relief than corticosteroid injections down the line.
Steroid injections, always a popular topic. What's the verdict on those for tennis elbow?
While they can give pretty impressive short-term relief, patients often feel much better quite quickly in terms of pain and function.
But there's a catch.
There seems to be, yes. The evidence points towards a higher recurrence rate. So the pain is more likely to come back, say, around 6 weeks or a few months later, compared to if they'd used NSAIDs or just bracing and physio.
And repeated injections.
Generally discouraged. They seem to become less effective each time, and there's some concern they might actually weaken the tendon over time. Plus, they carry risks like post-injection flare-ups, skin thinning or discoloration at the site, and maybe even a slightly higher chance of needing surgery eventually if they don't work.
So good for a quick fix sometimes, but maybe not the best long-term strategy.
That seems to be the consensus, yeah.
Yeah.
Use them judiciously, if at all, and educate patients about the potential downsides versus the short-term gain.
Okay. What about other modalities? Shockwave therapy? ECSWT?
Extracorporeal shockwave therapy. It's used for some tendon issues, but for tennis elbow, the evidence is a bit Yeah. Generally considered less effective than other options we've discussed. Not usually a first-line choice.
Right. But physiotherapy sounds like a mainstay.
Oh, absolutely. Physio is crucial. A good program will involve several elements.
Like what?
Things like therapeutic ultrasound, maybe phonophoresis that's using ultrasound to help drive topical meds deeper. Electrical stimulation can sometimes help with pain. Manual therapy is huge, soft tissue mobilization, maybe some joint manipulation if needed. Friction massage over the tendon.
Stretching and strengthening too, presumably?
Definitely. Specific exercises to gradually load and strengthen the wrist extensors and improve forearm muscle balance. They might also address things like neural tension, if that's contributing, and maybe techniques like instrument-assisted soft tissue mobilization, like Graston.
And does physio generally work well?
Yes. The success rates reported are actually very good. With a comprehensive program and patient adherence, a large majority of patients see significant improvement within about a year.
That's encouraging. What about less conventional things? Acupuncture, laser.
Acupuncture.
Yeah.
Well, the evidence is pretty limited. Some small studies suggested maybe some pain improvement for a couple of months, but it's not strong evidence overall. Kind of homeopathic in nature for this condition based on current data.
And laser therapy.
Similar situation. The data on low-level laser therapy for tennis elbow is really inconclusive for both short and long-term benefits, not something strongly recommended based on evidence.
Okay. Then there are the injections using the patient's own blood products, PRP.
Right, autologous whole blood injections or platelet-rich plasma PRP. The theory is sound concentrate the growth factors from the patient's own blood and inject them into the damaged tendon to stimulate a healing response.
Does it work better than steroid injections?
The research is still ongoing and somewhat mixed, but there's growing interest. Some studies suggest it might offer better long-term results than corticosteroids, but it's often more expensive and might require multiple injections. It's an area that's definitely evolving.
So lots of non-surgical options, but what if none of them work? When is surgery considered?
Surgery is really reserved for cases where patients have had persistent, significant pain and functional limitation for at least 6 months, despite a good try at comprehensive conservative management.
6 months is the usual benchmark.
Generally, yes. 6 to 12 months of failed non-operative treatment. And of course, you absolutely have to be sure you've ruled out other causes of pain before proceeding.
Makes sense. What surgical options are there?
There are a few main approaches. One is arthroscopic surgery. Using a camera and small instruments inside the joint allows the surgeon to debride or clean up the pathological tendinosis tissue at the ECRB origin. Sometimes they might release part of the tendon.
Minimally invasive.
Right. Another common method is open surgery. This usually involves a small incision over the lateral epicondyle. The surgeon identifies the ECRB tendon, releases it, excises the diseased portion, the gray degenerated tissue, maybe drills small holes in the bone to promote bleeding and healing, and then repairs the defect or reattaches healthy tendon.
And how successful is open surgery?
Generally quite good. Success rates, meaning significant pain relief and improved function, are often reported in the range of 85 to 90%.
That's pretty high. Any other techniques?
There's also a newer, minimally invasive technique called percutaneous needle tenotomy, often guided by ultrasound.
How does that work?
Under local anesthetic, the physician uses ultrasound to guide a needle repeatedly into the tendinotic area of the ECRB. This fenestration, making multiple small punctures, aims to break up the diseased tissue and stimulate a healing response. If there's calcification, the needle can help fragment it. They might also abrade the bone surface slightly. Often, they'll inject a bit of steroid and local anesthetic at the end.
And how does that compare to open surgery?
Some studies suggest it might offer similar or even slightly better short-term outcomes compared to open surgery, likely with a faster recovery being less invasive. But long-term comparative data is still being gathered.
Wow, okay. We've really covered a huge amount there, from the basics right through to surgical details.
Yeah, it's a common condition, but there's quite a bit to understanding the pathology and the range of treatments.
Absolutely. It really highlights how what seems like a simple elbow pain involves understanding tendon biology, biomechanics, and a whole spectrum of management options. Hopefully this deep dive has given everyone listening a much clearer picture for their exams and, for managing patients effectively.
Definitely. Accurate clinical assessment is paramount, and then tailoring the treatment based on the patient, the duration of symptoms, and the evidence for each approach.
So just to quickly recap the key takeaways. Tennis elbow means pain on the outside of the elbow, typically from tendinosis of the ECRB, worsened by wrist extension and gripping. Diagnosis. Primarily clinical, look for tenderness near the lateral epicondyle and pain with resisted tests like wrist extension, Mills, or Maudsley's. Management starts conservative. Modify activities, maybe ice or bracing. Physio is key. NSAIDs can help pain. Steroid injections give short-term relief but have higher recurrence. PRP is an option being studied. Surgery is usually only for persistent cases after 6 months of failed conservative care.
Good summary.
Thinking about all this, what factors do you find most critical when deciding on the management path for your patients with this? Something for our listeners to consider in their own practice.
That's a great reflective question. Patient expectations, activity levels, previous treatments. It's very individual.
Indeed. Well, that brings us to the end of this deep dive.
Hope it was useful.
Join us next time on Medsimu Medicine Podcast for another exploration of a key medical topic.